Thank you so much, Dr. Glees. Hi, everyone. For those who don't know me, my name is Sam. I'm one of the fourth-year urology residents at UBC. I was actually moving this past weekend, and I've stationed my laptop beside the modem as close as I can. So if there's any internet problems, I apologize in advance, but I did my best to try to avoid it. So today, my topic is pelvic lymph node dissection and prostate cancer. I want to especially thank Dr. Black, who reviewed the presentation with me and gave me the idea for the presentation. So the four key objectives I wanted to go over today. First thing I'm going to do is I'm just going to go over the prostate cancer risk stratification. There's a couple of different models that we can use to look at that. Then I'm going to go ahead and try to explain the prostate lymphatic drainage. There's multiple different pieces of literature, and it can be a bit of a confusing concept, so I'll do my best to try to explain it from what I gathered. And then I'll dip into available nomograms that are a tool that urologists can use in deciding when it's appropriate to perform a pelvic lymph node dissection. And then really I'll delve into the evidence behind pelvic lymph node dissection itself and whether it gives us therapeutic value, whether it helps patients long-term. And there's been quite a few papers that have come out recently that I'm going to discuss and try to answer those questions. So brief overview, I won't spend too much time on this, but prostate cancer is the most common cancer in men. Risk factors, as you get older, it increases the risk of developing prostate cancer. Family history is a key risk factor. If you have a first-degree relative, it generally doubles your risk of developing the disease. 2 or more first-degree relatives, that bumps your risk up to about 5 to 11 times. Patients of African descent have increased risk factor developing prostate cancer. There's also metabolic syndrome that's been found to be associated with prostate cancer. Although interestingly, when I was going through the literature, there's no good evidence to suggest that if you actually change your lifestyle or modify your diet, it reduces the risk, but intuitively one may think it would. There's always genomic considerations in prostate cancers, BRCA2, BRCA1, PTEN, TP53 Lynch syndrome. That should be considered in anybody with family history, certainly of prostate cancer. When you get the diagnosis of prostate cancer, this is the staging, the TNM staging that basically comes to mind. The one component that I want to draw attention to that I'll touch on later on again is the node metastases being present. So when you have lymph node invasion, whether it's 1 positive node or 6 positive nodes, you get assigned N1, and there's no real differentiation in the TNM staging, and that becomes relevant when you're looking at prognostic factors and treatment options for patients that have lymph node invasion on pathology. And that's something I just want to throw out there to keep in everybody's mind when I come back to it a bit later in the presentation. So in terms of risk stratification, generally it's done on a patient's PSA, DRE finding, amount of cancer on biopsy, and that's usually the number of total cores with the maximum amount in a core. And we also have grade groups, the International Society of Urological Pathology. And generally the purpose of this grade grouping is to align prostate cancer grading to grading of other carcinomas. You also see differentiation of 3+4 to 4+3. And as I'll talk about later too, there's certain evidence to suggest that the higher the grade, the higher the risk of biochemical recurrence. It's worth noting for risk stratification, however, that the AUA also includes PSA density and imaging when they're performing their risk stratification. Now, this is an extraordinarily busy slide. I don't want to spend too much time on it. The things I just want to highlight is this is the National Comprehensive Cancer Network guidelines for prostate cancer staging and risk stratification. The things that I want to take away here is basically you have this diagnosis based on PSA, DRE, and the Gleason score, depending on life expectancy and further staging workup, then you're categorized into very low, intermediate, high, or very high risk. And I'll break those each down in the subsequent slides. So for very, very low risk prostate cancer, for example, if you have T1C or lower, Gleason score 6 or less, well, 6 being the lowest realistically, PSA less than 10, fewer than 3 prostate biopsy cores or less than 50% cancer in any core, or PSA density less than 0.15, and they look at your expected patient survival, and subsequent treatment modalities are recommended. Now, what's interesting is in the very low risk prostate cancer group, they put radical prostatectomy as an option, plus or minus pelvic lymph node dissection if predicted probability of lymph node metastasis is greater than or equal to 2%. The greater than or equal to 2% is based on the nomograms, which I'll discuss shortly. But what's interesting is if you actually, and presumably they use the MSKCC for the nomogram calculation, but if you actually type in these numbers for their risk group, you can't get to over 2%, or you can't even reach 2%. So based on their own definition, you'll never meet the criteria to get a pelvic lymph node dissection, but it's still part of their criteria here. The same applies for low risk prostate cancer. They have the plus or minus pelvic lymph node dissection, but again, if you put in those numbers, I played around with the nomograms, you can't actually reach those numbers. So generally speaking, for very low risk, they don't recommend pelvic lymph node dissection. And this is in line with the EAU, AUA guidelines who don't recommend pelvic lymph node dissection in low risk category prostate cancer patients. But of course, as you go higher up, intermediate risk, now you have the T2B, T2C, or Gleason score 7 or higher, or Gleason score 7 or PSA 10 to 20, then the standard of care if you're performing a radical prostatectomy is to perform a pelvic lymph node dissection. And certainly for the high risk and the very high risk, the same management is recommended. So the key takeaways, as I mentioned, along with AUA and EAU, intermediate high risk patients should have a pelvic lymph node dissection based on these set of guidelines. And this is a nice kind of summary table to highlight what I was mentioning. So the EAU uses multiple different nomograms at their disposal for Ganti, MSKCC, or Roche, and their definition is if greater than 5% metastases is seen in the nomogram, they suggest performing an extended pelvic lymph node dissection. That's a pretty significant dissection. So by their definition is removing the nodes overlying external iliac artery vein, nodes within operator fossa, cranial and caudally operator nib, and the nodes medial and lateral to the internal iliac artery. AUA generally has a recommendation that's pretty open to interpretation, but then NCCN, which I was just talking about again, if you do meet the criteria to perform a lymph node dissection, again, they recommend the extended technique. So removing all nodes, bearing tissue by the external iliac, anteriorly, pelvic sidewall laterally, bladder wall medially, or the pelvis, Cooper's ligament distally, and internal iliac artery proximally. So you go from very low risk patients where recommendation is not to do pelvic lymph node dissection to the higher risk patients where recommendation is to do an extended pelvic lymph node dissection. And we'll talk about the evidence behind those a little bit. Now, important to highlight the template. So I mentioned the recommendation there where they discuss extended pelvic lymph node dissection. So when looking at the evidence for the template for prostate cancer, whether it's limited, extended, or super extended, it's quite heterogeneous. There's no agreed upon template in the literature. So what I've done here is try to summarize the consensus of what I found in different papers I read. So when you hear limited, oftentimes it's a synonym for standard lymph node dissection, and that involves removing the nodes of the external iliac and the obturator node. So just under the external iliac vein to the obturator nerve, whatever node package you see there, that would be considered limited or standard. Extended pelvic lymph node dissection generally means the nodes, basically the limited standard plus internal iliac nodes meet the criteria for extended pelvic lymph node dissection generally. And super extended is basically extended plus common iliac nodes to the level of the ureteral crossing and pre-sacral nodes. So this is just the definitions that I wanted to put out there. And you'll actually see in the presentation that I give some of the papers that discuss these definitions are not at all in line with what I just mentioned. So it's a bit of a muddied field. So in terms of pelvic lymph node anatomy, again, I scoured a few different papers, and the consensus that I found is generally the definition that's given for the route of drainage is the lymphatic drainage or periprostatic subcapsular network that then leads to one of three groups of ducts, and it's ascending duct, lateral duct, posterior duct, this doesn't necessarily tell us a lot when it comes to prostate cancer and lymph node dissection. Generally, these kind of pathways have been described for a long time, but there's been no clear primary or secondary lymphatic landing sites described or percent of distribution along this site. So knowing primary, secondary landing sites can allow us to better understand how successful we are in node dissection, depending on the extent of the dissection that's performed. So this was a study done by Matei in 2008, published in a European journal of Urology. It's a fascinating study where they used single photon emission computed tomography, or SPECT, fused with CT or MRI to determine the prostate's primary lymphatic landing sites after prostate injection of a nanocolloid. And they used intraoperative gamma probes to verify this. So what they did is on 34 patients with biopsy-confirmed T1, T2 disease, no metastases, no lymph nodes greater than 1 centimeter, no prior treatment or pelvic surgery, the day before the surgery, each prostate lobe was injected with these nanocolloids. And this was done under ultrasound guidance with fractions injected into the peripheral zone, mid portion, and the base. And 1 hour after injection, the SPECT imaging of the pelvis and the abdomen was performed. Now, at the time of surgery, the prostate lymphatic drain regions were examined using a standard gamma probe, and they defined background radioactivity to be determined over the sacrum and the IVC. And if they saw focal intensity, signal intensity of greater than 2 times of the background radioactivity signal, this was suggestive of lymph nodes. And so this was a nuclear medicine specialist and a urologist working together to try to figure this out. And you can see that this is basically what these were the definitions of the extent of lymph nodes as defined by the image. So what they found was 317 lymph nodes were seen on this imaging modality, the SPECT and CT MRI fusion. They were actually able to confirm 314 of them, 99% of them, using intraoperative gamma probes, and 300 of the 314 were surgically removed. And the 14 that were not removed was due to difficult surgical access or increased risk of complication. Now, the fascinating part about the study was that of the 317 lymph nodes, 120 were in the external iliac and obturator region, 81 internal iliac, 26 presacral perirectal, 50 common iliac, 38 para-aortic, pericaval, with 2 in the inguinal region. So that means if you performed a limited pelvic lymph node dissection, you're only capturing about 38% of the lymph nodes. And if you went on to perform an extended pelvic lymph node dissection based on a definition that I mentioned, you were capturing about 2/3, about 63% of the lymphatic channel. So it's a pretty cool study to highlight that you're not necessarily getting the majority of the lymphatic drainage, depending on the extent that you do. Now, obviously, not everyone has access to SPECT and gamma probes. So what is the typical standard and the next steps when you have someone be diagnosed with prostate cancer? So you have to have the appropriate conventional imaging to see or highlight whether the patients have lymph node invasion on imaging. So right now, the conventional imaging based on the recommendations is if you have, again, low risk, there's no further imaging that's recommended for staging purposes. But if you have intermediate risk or high risk, the typical standard right now is to get CT of your abdomen, pelvis, and a bone scan. But what about PSMA scans? Now, PSMA is definitely making more noise for salvage situations. When you have patients for recurrences, PSMA has certainly been a very useful tool. And for those who don't know, PSMA stands for prostate-specific membrane antigen, and it's a cell-surface glycoprotein found to be overexpressed in prostate cancer cells. When you perform a PET CT, it's essentially able to identify the radiolabeled molecules that bind with high affinity to PSMA. So the question is, can we use PSMA as part of our staging process to accurately diagnose the positivity of nodes before going to procedure? This was a recent paper published actually in last year in the Lancet by Hoffman and colleagues. There's a multi-center 2-arm randomized trial across 10 centers in Australia, and they looked at patients with high-risk features with at least one of PSA over 20, ISUP grade group 3 to 5, clinical stage greater than or equal to 3. And what they looked at was, and what they did was they randomized patients to conventional imaging, being CT of the abdo-pelvis bone scan or PSMA PET scan. 21 days after randomization, these patients had their imaging that they were randomized to. And 14 days after that, they had crossover imaging, so the other modality. And at 6 months' time, they repeated imaging as per the randomized cohort that they were assigned to, if they had evidence of N1 or M1 on the original imaging 6 months prior, or if there was biochemical or clinical suspicion of recurrence. So what they were looking at was accuracy of first-line imaging, identifying pelvic nodes or distant metastases. And the accuracy was determined by the area under the curve, which was calculated as mean of estimated sensitivity and specificity. And they use a reference standard, which is determined by presence of pelvic nodes and distant mets at 6 months' time. And this was considered positive if you had one of two hard criteria, being the histopathology demonstrating prostate cancer from the nodes, or change of bone lesions from to sclerotic blastic on follow-up imaging, or they had to meet 3 of the following 9 soft criteria. I don't know how well you can see it in this diagram, but basically, typical appearance of multifocal disease, metastatic lesion appearing, increase in number of bone lesions, or decrease after appropriate treatment, etc. So you need to have 3 of the following for it to be considered positive. And the secondary thing that they looked at, a secondary outcome, was whether these imaging modalities changed management outcome for physicians and the patients. So a management questionnaire was given to physicians who had decided in a multidisciplinary group what the next course of treatment would be. And it kind of looks something like that. And, you know, the questions on the basis of first-line imaging: is there a plan to alter and the intended management? And they repeated the questionnaire after the first and second line imaging. And what they were looking at and questioning is whether the imaging modalities changed management planning. And they grouped it into 3 different groups. It was high level of change, medium change, low level of change. High level of change was defined as change in management modality or intent. For example, their original plan was curative. However, based on imaging, they became palliative. Medium was change in modality delivery, and low was management plan was not altered. And with the results, what they found in their, with respect to the primary endpoints, they found PSMA PET scan showed a 27% absolute greater AUC for accuracy compared to conventional imaging. That was 92% versus 65%. Sensitivity of the PSMA was 85% compared to conventional imaging being 38%. Specificity was 98% in PSMA and 91% in the conventional imaging. And when they considered equivocal lesions to be considered positive in a sensitivity analysis, it further showed PSMA superiority of 89% versus 61%. When they looked at the subgroups for patients with pelvic nodes, the PSMA scan showed an AUC of 32% greater, and distant mets 22% greater, and which showed clear superiority. Management, this is the part that I found quite interesting. Management change is conferred in high medium effect in 15% of conventional imaging compared to 28% of the PSMA group. 20 men in the PSMA group had their intent changed from curative to palliative. And interestingly enough, they also have a data point down there where radiation exposure was known to be higher in conventional imaging compared to PSMA PET. So it was a very fascinating finding. Obviously, PSMA is making more further advances in terms of how it can be utilized, but it was a very fascinating paper to read for imaging workup and staging workup for patients. But it's not the gold standard yet, and most often physicians and surgeons and that have a patient with prostate cancer and trying to decide what the next course is going to be, they're not always going to have the fancy imaging modalities available. So one thing that's commonly used is nomograms to decide whether patients should receive lymph node dissection. And basically what a nomogram is and there's multiple different nomograms, as I'll highlight here, 6 of them. It's a practical tool at a surgeon's disposal to determine, based on their clinical parameters, whether the formula that's been accumulated based on each different nomogram suggests or recommends a pelvic lymph node dissection. And these are all fairly similar with little discrepancies. Briganti 2012, which is now outdated, looked at PSA, clinical T-stage, primary, secondary lesion scores, percent of positive scores. And if you had a score of greater than or equal to 5%, extended pelvic lymph node dissection was recommended. Briganti 2017, which took over for 2012, was fairly similar. And then 2019 started incorporating multiparametric MRIs, and their threshold changed. So if you put in the clinical information and it was over 7%, then they recommended pelvic lymph node dissection, again, extended pelvic lymph node dissection. And their rationale is using that nomogram, you would avoid 60% of extended pelvic lymph node dissection procedures at the cost of missing only 1.6% of lymph node cases. Now, just to give you an example of what a nomogram looks like, I quickly found it online. This is the 2019 Briganti. You just put in a bunch of different clinical details, and it pumps out a calculated number. For example, for this fake patient that I made up, it was 10.3%. So the recommendation would be an extended pelvic lymph node dissection. So practically speaking, what do? You have all these nomograms at your disposal. Is there one that's better than the other? And fortunately, someone tried to answer that question for us. So this was a paper that was published in September of 2020, Ordera and colleagues. So they basically sought to externally validate MSKCC and the 3 Briganti nomograms, Partin and Yale formula, and to also evaluate potential risks and complications associated with extended pelvic lymph node dissection. This is a retrospective study that spanned over 27 years, and the template used was an extended pelvic lymph node dissection, but in their definition was obturator, internal, external iliac lymph nodes up to the ureteric crossing. After exclusion, 12,009 individuals were assessed, of which only 609 had undergone MRI, and the typical clinical data was identified, such as their PSA, their Gleason scores, their clinical stage at the time of diagnosis. And they also looked at extended pelvic lymph node dissection complications such as lymphocytosis, lymphedema, bleeding, infection, sepsis. They used previously published regression coefficients to calculate individual risk of lymph node invasion, and their models were evaluated in terms of discrimination and calibration. And they quantified discrimination as area under the curve area under the curve analysis, and extent of over and underestimation associated with the model graphically described using calibration plots. And they finally performed a decision curve analysis to assess for any net benefit of each nomogram according to the threshold. So what they found is each nomogram is fairly comparable to one another. There's no single nomogram that's significantly better than another one at baseline. Of interest, they found that 1,158 patients, or only 9.6% of patients, had lymph node invasion on final pathology. So of all the patients that extended pelvic lymph node dissection was recommended in, only about 1 in 10 actually had positive pathology. And this is with an average of almost 18 nodes being resected. So to put things in perspective, if you use the 5% threshold for the Partin formula, about 1 in 5 patients who did not have lymph node invasion would receive a pelvic lymph node dissection. And about 3/4 of patients would have no lymph node invasion in the Briganti 2019 nomogram, but would have received an extended pelvic lymph node dissection. Now, Briganti 2019 upped their threshold to 7%. So even with that, 58.6% of patients without lymph node invasion would have required an extended pelvic lymph node dissection as per the guidelines. Now, this is a bit of a busy slide, but basically in the calibration plots, the top 2 are the MSKCC and the Briganti 2012. And what they found is that for patients that have a less than 20% probability of lymph node invasion, they're typically underestimated with actually having true lymph node invasion, but they're overestimated in patients with greater than 20% probability. Partin and Yale generally underestimate. Briganti 2017, 2019 generally overestimate lymph node invasion. And when they performed a decision curve analysis to evaluate the net benefit of the model according to the threshold that they used, all models generally showed a net benefit with less net benefit for the Partin and the 2019 Briganti when probability was less than 20% of invasion. Now, when they made a direct comparison between different nomograms, there was better discrimination achieved in MSKCC, and they outdated Briganti 2012. So overall, they concluded that MSKCC and Briganti 2012 were better at predicting lymph node invasion in patients who received systematic biopsies. They suggest that NPMRI may not necessarily add as much value, but it's a bit biased in terms of the sample size. A lot of these patients' data were before 2015, and a lot of the patients had not received MRI. So I'm curious to see how much the data would change if there were more data points for patients that actually had MRI targeting biopsies. Now, one thing I want to highlight is the complication rate. So pelvic lymph node dissection related complications were experienced in 6.4 to 11.3% of patients without lymph node invasion. And so pretty significant amount of patients had the complication without positive pathology. Overall complication rate was 8.9% and 12.6% in the N1 patients. I want to highlight the lymphocyte data, and that's a pretty significant complication that you could have. And there's some data that suggests that lymphocytes are associated with thromboembolic events. There was a study by Mush and colleagues in 2008 that was published in the Journal of Urology that looked at lymph node complications and found that patients with lymphocytes had 8.3% prevalence of developing a DVT and 2.8% of developing a PE, with less than 1% of the groups that did not have lymphocytes postoperatively. And that was a study of over 1,300 patients. There's also the possibility that they did not know here of nerve damage, most common being the obturator nerve. And certainly in extended pelvic lymph node dissection, the further you go, removing nodes medial to ureters, periaortic, caval, perirectal, presacral regions can increase risk to autonomic sympathetic fibers that can compromise continence sexual function. So it's definitely something to keep in mind when deciding whether we're performing the pelvic lymph node dissection on patients. So far, what I've hopefully done is discuss risk stratification, imaging in terms of how to pick up lymph nodes, nomograms, and deciding, well, if you have a certain number and the suggestion is performing a lymph node dissection, it's based on a risk, the fact that the patient likely has lymph node invasion. So is there actually any true benefit, though, to performing pelvic lymph node dissection? In spite of advances in imaging and CT, MRI, and I mentioned the PSMA, the gold standard, if you look in the literature right now for nodal staging, is performing pelvic lymph node dissection. It's key for pathological staging and potential treatment of patients moving forward. But what's more controversial is if there's any true benefits to patient prognosis in performing an extended pelvic lymph node dissection. And there's actually been quite a few studies that have come out recently. The first one I'll discuss is a little bit older, in 2017. And I think let's see that better. So basically, this is a study by Prostate in 2017 that was published in European Journal of Urology. And they looked at 66 studies, which consisted of over 275,000 patients. And what they looked at is their objective was to evaluate the benefits and harms of pelvic lymph node dissection when considering different templates. So that was no pelvic lymph node dissection, limited, standard, extended, super extended. And more specifically, they were looking at their primary outcome that they're looking at was biochemical recurrence, clinical recurrence being distant metastases, cancer-specific survival, and overall survival. And their secondary outcomes were adverse outcomes, complications, along with functional outcomes such as urinary incontinence, erectile dysfunction. And this is the template they used. Again, it's a little bit different than the old diagram that I put from a different study, just to kind of show how heterogeneous the field is. Now, to control for heterogeneous definitions of pelvic lymph node dissection, they established 6 extents for this study. So again, it was no pelvic lymph node dissection, limited being obturator nodes, standard being obturator and external iliac nodes, extended being obturator, external iliac, and internal iliac nodes, and super extended being essentially extended pelvic lymph nodes plus common iliac, presacral, plus other nodes. And finally, their 6th category was essentially undefined or unclassified. And what they found, they had 2 different sets of results, oncologic and non-oncologic. With respect to the oncologic outcome, they found when they, in the papers that discuss pelvic lymph node dissection versus no pelvic lymph node dissection, that there was no good quality evidence that any pelvic lymph node dissection showed benefit with regards to biochemical recurrence, distant metastases, or survival. 16 out of 18 studies didn't demonstrate any significant differences. This was even after subgroup analysis was performed. 2 studies looked at distant metastases and reported conflicting findings. There was a study, one of the studies was Mitsuoka and colleagues that looked at standard versus no pelvic lymph dissection. They found no metastases at 60 and 26 months, respectively. And counterintuitively, there was a study done by Bowman colleagues that found no pelvic lymph node dissection had a lower risk of metastases and biochemical recurrence. I haven't been able to find another paper that replicated that, but worth noting. 6 studies looked at cancer-specific survival and overall mortality, and no evidence was seen in terms of benefit for either cohort. Now, when they looked at limited standard versus super extended, again, they saw 6 out of 8 studies that showed no net benefits in extended pelvic lymph node dissection. They weren't able to identify any studies on distant metastases, and only 1 study looked at cancer-specific survival, which is Nioshko and colleagues in 2013 paper that found no net benefit. But the limitation in that study was that there was only a 34-month follow-up associated with it. Now, when they looked at non-oncologic outcomes, when they looked at pelvic lymph node dissection versus no pelvic lymph node dissection, they found that 12 out of 16 studies demonstrated pelvic lymph node dissection to be associated with significantly greater risk of lymphocyte formation. And 3 studies evaluated, interestingly, 3 studies evaluated there was no difference in erectile function, recovery, or urinary incontinence. So the functional outcome was fairly comparable. With respect to the lymphocyte complications that I mentioned, there was one of the papers that they discussed was by Cole and colleagues in 2015 that found a higher 90-day mortality in patients with pelvic lymph node dissection in both open and robotic approaches. Now, they didn't meet statistical significance, but of course, it's worth noting given clinical significance. There was multiple retrospective studies that had variable findings. And one thing to take away that I'll discuss again too as part of their own conclusion is the data wasn't great in their analysis. You know, you would see 15 studies that would all say different things. 5 studies showed increased risk of complications post-op. 5 didn't show any differences. But regardless, 12 out of 16 found that general complication rates are higher if you perform pelvic lymph node dissection, which does make sense intuitively. And when they looked at limited standard versus super extended, again, conflicting evidence, there was one paper by Listingi that found statistical significant increase in operative time, intraoperative complications, bleeding, and hospital stay. But another study by Schwarfeld and Bohr did an RCT and found the only complication was a lymphocyte formation for the pelvic lymph node dissection group. But of course, that's a pretty significant event, but no difference in erectile function, recovery, urinary incontinence. So once again, the takeaways from this paper was that there was no clear therapeutic benefit in performing pelvic lymph node dissection, and there are significantly higher risks for complications. However, there was significant limitations associated with the study. At the best of times, there was moderate to high grade of bias associated with the majority of the papers. And the authors mentioned that we do need better data to answer the questions regarding pelvic lymph node dissection versus no pelvic lymph node dissection. But still, it was quite fascinating to find so many studies did not find any significant difference in things like biochemical recurrence, cancer-specific survival, et cetera. So a more recent publication, actually as of last year, by Pricer and colleagues in the Journal of Urology, looked at 32,865 patients who underwent radical prostatectomy over a course of 17 years. And they looked at intermediate high-risk patients that were included in the analysis. And they used the MSKCC and Briganti 5% nomogram for patients that have the Briganti 2017, where they demonstrate if you have a greater than 5% chance of invasion that a lymph node dissection should be performed. And this study was done at 4 European tertiary centers. And after inclusion criteria was met, 9,742 patients were analyzed. And the endpoints they looked at was biochemical recurrence, which was defined as 2 consecutive PSAs of 0.2 or greater, or rising PSA after surgery. metastases-free survival, which was defined as no radiologic signs of mets and follow-up imaging, and cancer-specific mortality, which was basically death attributable to prostate cancer. To account for potential differences in no dissection versus not, they performed a 2-to-1 propensity score, and they basically use a propensity score to match the cohort balanced by the pathology, PSA, surgical margins, and they performed a Kaplan-Meier analysis to demonstrate graphically their endpoints. They also performed 2 sets of multivariable Cox regression models to test the relationship between pelvic lymph node performance with respect to different endpoints. So their first one was done for postoperative covariates such as age, year of surgery, preoperative PSA, pathologic tumor staging, margin status, primary pathology, and the Gleason score. And the second one was done for pre-op covariates such as age at the time of surgery, year of surgery, PSA, clinical tumor stage from the biopsy Gleason score. So what they found was 7.3% of patients did not undergo extended pelvic lymph node dissection. And that's interesting because all of them had met the criteria as per the Briganti nomogram to get pelvic lymph node dissection. But still worth noting that in their results, they found that the biochemical recurrence-free survival at 120 months, there was no clinical significance. There was no statistical significance found between the cohort that received the pelvic lymph node dissection versus the one that did not, and no independent predictors were identified in either multivariable regression model. When you look at metastases-free survival at 120 months, same thing, they did not find any statistical significance between the 2 cohorts, and no independent predictors were identified in either regression model. And with respect to cancer-specific mortality at 120 months, once again, no independent predictors were identified. So what's interesting in this paper is that not everyone that should have gotten extended pelvic dissection as per AAU and NCCN recommendation did get a pelvic lymph node dissection. And this is a major limitation of the study because it didn't actually discuss why certain patients did not receive a pelvic lymph node dissection. So it's a very fascinating outcome, but that was a major limitation to not knowing why certain patients did or did not. There could be a selection bias associated with that, but it wasn't discussed in detail. So what I've discussed is a lot of systematic reviews, but very limited prospective randomized trials in the field regarding the benefit or harms of extended pelvic lymph node dissection. The key thing I want to highlight here is that the recommendations as per the guidelines is, as I mentioned before, to go to extended pelvic lymph node dissection if you meet a certain threshold on the nomograms. And there was one paper that was recently published, actually, which looked at limited pelvic lymph node dissection versus extended. So if you're going to perform pelvic lymph node dissection, does it need to be extended? Because as I mentioned, that increases risk when you do have that. So this was a phase 3 randomized trial. Looked at patients with intermediate or high-risk prostate cancer that were enrolled over 4 years in Brazil. And patients were randomized to limited or extended pelvic lymph node dissection. Exclusion criteria was basically prior surgery, prior hormone therapy, presence of metastases or malignancy, and they were randomized 1-to-1. Extended pelvic lymph node dissection was defined as obturator, external iliac, internal iliac, common iliac, and presacral region bilaterally, whereas limited was the obturator region only. So post-operatively, they looked at PSAs that were scheduled at 1, 3, 6, 12, 18, 24, 30, and 36 months, and annually thereafter. Biochemical recurrence was confirmed with a second PSA. Patients were then restaged using bone scan and MRI. And with confirmed biochemical recurrence, patients underwent salvage radiation therapy if PSA was slow to rise, and they received androgen deprivation therapy if the doubling time was less than 6 months. And the endpoints they looked at was primary 5-year biochemical recurrence survival and secondary metastases-free survival and cancer-specific survival. So these are the findings in terms of how many nodes were dissected for the extended versus limited. Obviously, the extended group had significantly more nodes in their pathology. And as I mentioned earlier, the more nodes you dissect, the higher the likelihood that you're going to have positive nodes found in pathology. And this was demonstrated in this study. Something to highlight is 65% of the nodes were found in the internal iliac region, which is different than the earlier picture that I showed from the Matei paper. So Also, this may suggest that a lot of the times if we're not performing dissection of the internal iliacs, that we're missing nodes, quite a significant number of nodes. So in terms of oncologic outcomes, the median biochemical recurrence-free survival was 61.4 months at limited pelvic lymph dissection, not reached an extended pelvic lymph dissection. But when they did the Kaplan-Meier estimate of biochemical recurrence-free survival, there was no statistical difference found, and they further found no statistical difference in metastasis-free survival or cancer-specific survival. The major limitation in this study was that the follow-up was not very long. The median follow-up was only 53.9 months, but in that time frame, once again, there was no data to suggest that there was any benefit to performing an extended pelvic lymph node dissection. When they performed a subgroup analysis of the ISUP grade 3 to 5, however, the Kaplan-Meier estimate showed that the biochemical recurrence-free survival was 12.34 months in the limited group, but not reached in the extended group. So there was a statistical significance in the higher risk cohort when evaluating biochemical recurrence. When they performed a forced plot effect of lymph node dissection, measuring biochemical recurrence-free survival by selected baseline pathological parameters, once again, the intention to treat analysis showed better numbers for the group that did receive an extended pelvic lymph node dissection. Overall, however, the trial failed to show a significant benefit of extended pelvic lymph node dissection over limited pelvic lymph node dissection when looking at its primary and secondary endpoints. It did show better staging as expected when you perform an extended pelvic lymph node dissection, and it demonstrated some potential biochemical recurrence-free survival in patients with a higher ISUP score, but that's a study that needs to take care and that needs to perhaps be performed at a later time. But there's also a question of when you do have biochemical recurrence or when you do have N1 in your pathology, does that necessarily mean that you need treatment right away? Does that necessarily mean that your prognosis is significantly worse? And that goes back to what I discussed earlier, when N1 can mean a variety of things. It can mean 1 lymph node, can mean 5 lymph nodes. And that there's a paper that actually discussed this by Mara and colleagues that was published last year. And basically, given the lack of level 1 evidence for contemporary patients, they performed a systematic review for patients with N1 disease who underwent prostatectomy and pelvic lymph node dissections in the hopes of determining optimal postoperative management. They looked at prognostic factors that they found can help guide management, as once again, N is considered 1 regardless of the extent of invasion. So what they did is they looked at retrospective studies that had at least 100 patients in them with N1 pathology, non-metastatic patients, and they looked at overall 26 studies, 23 of which were retrospective, 3 RCTs, and the primary outcome they looked at is cancer-specific survival, with secondary outcomes in this case being biochemical recurrence-free survival, clinical recurrence-free, and overall survival. So they found in terms of prognostic factors, they found there was no significant impact of stage on overall survival. Year of surgery, external extension, side of lymph node invasion were not predictors for oncologic outcomes. They found that 5 out of 8 studies demonstrated associations of biochemical recurrence and positive margins with oncologic outcomes. But there wasn't a strong correlation found overall when you look at biochemical recurrence and prognostic factors. However, almost all the series showed association between pathologic Gleason score and prognosis, and number of positive notes, once again, showed a strong association with prognosis. In terms of postoperative management, when they looked at a group that they just performed observation in, 7 studies reported outcome of 1,370 some patients who were just observed with prostatectomy and pelvic lymph dissection. Biochemical recurrence was experienced in 62% of patients. But if I highlight the last point, the overall survival, 75% of patients were still alive at 5 years and 60% at 10 years. Now, this is at patients that received no further adjuvant therapy. Now, the patients that did receive adjuvant therapy, they showed that 6 studies that received adjuvant ADT, and they found biochemical recurrence-free survival ranged from 61% at 5 years, 56% at 10 years. 2 studies looked at cancer-specific mortality, which were 69 and 82.3% respectively at years 8 and 10. And the data wasn't great for adjuvant RT with and without ADT in this particular study, but the overall survival was 81 to 0.6% at 10 years. The main thing I want to highlight here, though, is, and there was a graph, there's a table actually in their supplements that I tried to put into the slides, but it wouldn't fit no matter what I did. It looked awkward. But the majority of patients who were observed in this slide, they had favorable characteristics. 63% of them only had one positive node. Gleason scores were all, and 2/3 of them were under 8, and negative margins were present in 62.5%. But patients who underwent the forms of treatment, the adjuvant forms of treatment, generally had more aggressive features. 39% of those with ADT had more than 3 nodes. 30% of the RT group had more than 3 nodes. Gleason score was greater than or equal to 8 in 2/3 of the group. So it really takes away the fact that when we're looking at patients post-operatively, they're not all the same. It really depends on what their pathology showed, what their Gleason scores were, and how many positive nodes they had to decide what the next step should be. So to bring it to an end, in terms of my conclusions, nomograms may not accurately predict lymph node invasion, but they're still a practical and easy tool to use when we're trying to decide whether we should perform a pelvic lymph node dissection. Pelvic lymph node dissection continues to be the gold standard for accurate staging, although there wasn't any good evidence to suggest that extended pelvic lymph node dissection provides better therapeutic value for patients, although its diagnostic offerings are hard to dispute. Risks and benefits should definitely be considered on an individual basis for patients to receive pelvic lymph node dissection and the extent that it is performed. And disease characteristics are a key part of postoperative management in patients found to have lymph node invasion. N1 can mean a variety of things depending on how significant of lymph node invasion there is and what other tumor factors and characteristics are present. So with that, thank you very much for joining me today. I'm happy to take any questions.